The same things except that it's a synovial joint. It has a multi-axial mobility. It has a fibrocartilage and has a meniscal homologue. So sometimes when you see that the AC joint is okay but the patient complains of pain, it might be that you get an MRI scan and you'll find the meniscal homologue is injured. So just be mindful of that in the type 1s and types 2s that are not resolving after 3 months of conservative management. So exactly what Dr. Gopal said, no differentiation on this. You have the shoulder arc and the pathologies of the ACJ. You have the Rockwood classification. And the same, the consensus is there. The problem is the type 3. And the type 2s who are painful. Type 1 generally doesn't bother. Type 4, 5, 6 need surgical treatment. Various things that he has described. So there's also a Mumford procedure where you just excise the lateral and leave it be. So this is a case, so a type 5. So difference between type 3 and type 5 is reducibility. So it's a type 5 ACJ in a 20-year-old male, right hand dominant, fall off a bike, which is the commonest method. So this is how I do them. So I do all my shoulders be chair. So this is the position. This is the shoulder you can see, and this is the setup. So you need an X-ray in this setup. So have room to maneuver that X-ray. And this is the video. Okay, so I am through the anterior portal, which is the standard rotator portal, and I can see, let the video run. Okay, so people can see. So what I'm doing is I'm trying to find the base of the coracoid. Once you find the base of the coracoid, then life becomes very, very easy. Until you find the base of the coracoid, you're just venturing into territory where you have the entire brachial plexus around somewhere. And as the shoulder keeps getting swollen, you lose the orientation even more. So you can see you've reached the base of the coracoid. And then once you reach the base of the coracoid, then you can make an anterolateral portal. Shift your scope to the anterolateral portal, which I'll show in the second case. You keep slowly dissecting the base of the coracoid. So because these guys are acute, or within the 3 weeks, you get a lot of edema, the tissues are battered and bruised. So one has to be mindful how you're dissecting it. You can see the base of the coracoid now. And then you shift portals. Okay, and then you have to use a jig. Once you have the base of the coracoid, use a jig to pass a drill, and then pass a nitinol wire through the drill. the biggest trouble is passing the button, because the button is quite big. So it requires a little bit of maneuverability to get the button on. And there are some steps that you'll probably appreciate more in the next case. So it's always best to deliver the button in. And then you can tie it onto the correct. So you always need the X-ray to see where you are. So you're not, and that is him. And that is him around, I think, 3 months down the line. And then they get full range of movement, there is no problems. That's a case 2. Again, a case 5. It's a 32-year-old female, right hand dominant. This is the left shoulder. It's a grade 5 separation, but you'll appreciate steps that you were not able to appreciate in the previous video. So that is the rotator interval. You come in through the rotator interval. And you start dissecting your rotator interval. So forward. Start going to the base of the coracoid.
So Gautam, because all the delegates here, I don't know whether they are routinely doing arthroscopy or not, shoulder arthroscopic AC joint fixation. So what are your tips, like how to start, who should try to do this?
So I think you have to do opens first, because then you understand the anatomy around it. Going arthroscopic, the first bits of arthroscopy is obviously, if you're doing arthroscopy, you need to do simple procedures first, like a cuff repair or a Bankard's. So you know your way around the joint, because as soon as you start going the rotator interval into the territory of the front of the shoulder, you have the brachial plexus there.
Because that is the point I wanted to give here.
Yes.
See, you should be comfortable doing routine shoulder scoping.
Absolutely.
And then
Absolutely.
you should try to
when I was training, my boss would say that when you're doing a routine, say Bankard, you have nearly completed your Bankard, try and see if you can dissect the coracoid. So go a little back, dissect the coracoid, come to the base of the coracoid. Once you can come to the base of the coracoid, end your surgery there. So the next time when you come around, you know where the coracoid is. You do that a couple of times, you understand where the coracoid is at the...
so what I am asking is, if at all you want to give some tips here,
correct.
So what is your tips, like how to reach this area, what portals, you mentioned?
So,
like,
so there are two portals going on this one.
Yeah.
So this, if you see this now, what's going on. So I've got the whole coracoid base uncovered. I am also struggling not to go too much medial, because I know brachial plexus is there, and I'm using a RF device. And then you can see a jig. So jig comes across, and you can put a needle, the pin through it. And the process is pretty much the same, but you need X-rays. That's one thing. Don't be brave and think I know everything and I know where it is, because the number of times you're going to find that your button is somewhere here. with your coracoid only pierce that way. And then you don't sleep well because you don't know with the forces that the shoulder is going to go through when that button is going to osteolize and break that piece of coracoid. And then you have another problem to solve. So the button has to be there. It has to be on the thickest portion of the coracoid. And that you can only delineate with X-rays. This is what you get. So you do them often, your surgical scars getting smaller and smaller. I started off like that. And I've ended up like that. And that is probably because it's a brass strap incision, it gets covered, it is more aesthetic. And then you have the anterolateral portal, an anterior portal and a posterior portal, and that's it, really. That's all you need. But to get to this stage takes time. So don't rush. It's okay if you can't be prepared to open up. You start off arthroscopically, examine everything. If everything is good, then continue. If you think you're struggling, the shoulder is swelling, no point in causing harm to the patient. Abandon, open up, do it.